Welcome back, friends. This is the concluding part or the miscellaneous part. I'm just going to cite some of the examples, some of the points you're supposed to remember, some of the negative points you're supposed to remember, and just in the end, I'll wish all the best to all my students. Some of the important points you're supposed to remember are, I have just mentioned a few. There may be a lot of them that you're supposed to remember, and practically you're supposed to remember all the lectures which I have already taught to you and go through the slides of each and every lecture. But some of the important or salient features I'm about to mention, just keep this in mind. It might be helpful to you for your exams. What are the causes of sudden decrease in end tidal volume? Now basically you should know what is end tidal volume. End tidal volume is whenever the patient is being ventilated and suddenly there is decrease in the gas flow. What may be the cause? If patient is anesthetized, patient is being intubated and you are ventilating the patient, gas is being filled in the bag of your brain circuit, but suddenly if you realize that the gas is not being filled in the bag, what may be the cause? The first thing that you should strike your mind is air embolism. Second thing, there may be a circuit leak. There may be accidental extubation of the patient, or patient may be having cardiac arrest. So what may be the cause of sudden decrease in end tidal volume? Just keep these 3 to 4 things in mind. There may be air embolism, there may be circuit leak, there may be accidental extubation by the patient factor or the doctor factor or by the clinician, and cardiac arrest. The second one of the important points which I want to make a note of is plasma cholinesterase. This degrades which of the following drugs? Just as I have mentioned during my lectures, succinylcholine is being degraded by plasma cholinesterase, that is, it is metabolized by plasma cholinesterase. The other muscle relaxant which is being metabolized by plasma cholinesterase is mivacurium. And now, since both these drugs are being metabolized by plasma cholinesterase, their duration of action is very small. The other drug which is metabolized by plasma cholinesterase is esmolol and cis-atracuria. The one thing is common in all the drugs which are metabolized by plasma cholinesterase is the duration of action of these drugs is very small. How do you induce hypotension? During the surgical course, sometimes surgeon asks the anesthetist, please, I want a hypotensive anesthesia. Please reduce the blood pressure. And to what extent can anesthetist reduce the blood pressure of a patient who is already anesthetized? How do you induce the hypotension? What are the drugs which you use? The first and foremost drug which you can use is NTG or sodium nitroprusside. You start a sodium nitroprusside drip. It can be used to produce artificial hypotension till such time that surgical field is clear, and once surgeon finishes his job, this NTG drip is shut off and again patient can be brought back to his original whatever normal blood pressure is there. So ultimately whenever the patient is anesthetized, his whole body, his whole life is in the hands of anesthetist. You can maneuver and you can change his blood pressure as per your will and wish of surgeon. You can change his blood pressure, you can change his pulse rate, and you can manage the whole of his human body with the help of drugs. Coming back to main drug which is used to induce hypotension is sodium nitroprusside or NTG, trimethoprim. Spinal or epidural block, as I have already mentioned, it produces hypotension. So this side effect of spinal or epidural block can be used to induce hypotension. Beta blockers sometimes can cause hypotension. Halothane is a drug which can be used to induce hypotension along with isoflurane. Sometimes positioning of the patient may be helpful to induce hypotension during the course of surgery. Now the next point to remember is methemoglobinemia. In what drugs can cause methemoglobinemia? This is an important question. It has been asked in the MCQs. Methemoglobinemia is seen in prilocaine. It is seen with xylocaine. It is seen with nitrous oxide and nitrous. It is seen with benzocaine. It is seen with sulfonamides. So you should always keep all these 4-5 drugs in mind. Whenever you see the word methemoglobinemia, it is seen with prilocaine, it is seen with xylocaine, it is seen with nitrous oxide and nitrates, it is seen with benzocaine, and it is seen with sulfonamides. And some of the negative points which you must know, that is, what is not caused by atropine. Sometimes questions are framed in such a way, they are not positive questions, they are negative questions. So imagine a question comes to you like, what is not caused by atropine? So one single thing that is not caused by atropine is bronchoconstriction, and your mind should be very clear. What is not caused by atropine is bronchoconstriction. What is not caused by ipratropium? Again bronchoconstriction. Ipratropium bromide, what is not caused is again bronchoconstriction. Another one of negative questions is like, not a vasodilator, local anesthetic. Practically all the local anesthetics are vasodilators. Only one, that is cocaine, is not a vasodilator, local anesthetics, which is not used for clearing airway, that is head lift. Whenever patient is being anesthetized or is in supine position and is full of secretion, his mouth and nose are full of secretion, what is the thing which you should not do? That is, you should not lift the head. So not used for clearing the airway is head lift. Bag and mask ventilation is contraindicated in only one condition, that is diaphragmatic hernia. Bag and mask should be cautiously used or is totally contraindicated in only one condition, that is diaphragmatic hernia. Then what are the drugs which are not used for induction in infants? In infants, one drug which should never be used for induction, and that is morphine. Which is the drug which is not used as a surface anesthetic? Procaine and bupivacaine. Because for giving surface anesthesia, you use other drugs, but procaine and bupivacaine are contraindicated and cannot be used for giving surface anesthesia. Which is the drug which is not used in Bayer's block? I have already mentioned is IV regional anesthesia. And which is the drug which is not used? That is bupivacaine. Bayer's block is always given by xylocaine and not by any other drug. Bupivacaine is only a drug which cannot be used to give Bayer's block. Not used for controlled ventilation. Which is the circuit which is not used for controlled ventilation? Now we all know Mapleson D and Mapleson F in case of pediatric cases are used for controlled ventilation, but Mapleson A circuit or Magill circuit is never used for controlled ventilation. Flat capnograph is not seen in what? Flat capnograph is not seen in bronchospasm. These are some of the negative questions which are likely to be asked or which have been asked. There you can frame your negative questions as you go through my lecture series, right from first lecture to the last, and you can come across, but I have tried to cover each and every aspect of anesthesia in as quickly and as easily as possible. I tried to make you understand basics of anesthesia and what a basic anesthetist has to do and what basic knowledge an anesthetist has to have. There may be some points which I may have missed, which may be covered at a later stage or during classroom teaching, but I tried to concise the whole subject of anesthesia in such a way, and I tried to make it as interesting as possible. I wish you all the best for your future endeavors, and I wish you luck that you will come out with flying colors in all your exams. Thank you very much.